Well, good afternoon, and want to welcome everybody to this happy hour session. Dr. Gammon was supposed to be leading the session, but unfortunately he had a medical issue come up with his daughter, so I'll be guiding us through the potpourri of slides today. If you have any questions, for those of you who are watching live, I will be monitoring the chat, and we'll check it from time to time. As always, if you have any questions or suggestions, you can feel free to email us at education@sagesdx.com, or you can email me directly, tdavis@sagesdx.com. So without any further hesitation, we'll go ahead and get started on the dozen or so slides that we'll be discussing today. The first biopsy specimen was actually from the nail unit. And a bit of history that you didn't have. The patient had an enlarging longitudinal melanonychia involving the thumb. It was about 5 millimeters wide, had enlarged over the last 18 months. It was somewhat of a streaky streak. And this biopsy was obtained near underneath the lunula in the area of the distal nail matrix. And this was a somewhat fragmented specimen, but a beautiful biopsy. In the top piece of tissue, if you'll follow my cursor, you can see the proximal nail fold heading back towards the cul-de-sac and the nail plate. And then beneath the nail plate, we've got nail bed and matrical epithelium. I believe this must be some nail fold, a portion of the nail fold. And then in the bottom piece of tissue, in these sections, we actually have matrical epithelium. And you can see the reedy or somewhat hyperplastic. And on higher power examination, hopefully what was readily apparent to you was the presence of several melanocytes, some forming nests, some as confluent solitary units, not only along the base of the matrical epithelium and the matrical layer, in the basal layer of the matrix rather, but also extending into the upper portions of the matrix in a Targetoid pattern. And there are way too many melanocytes here in the matrix. And these findings are highly suspicious for melanoma in situ. So with that being said, we'll go ahead and move on to slide number 2, which was a Melanoma or MART1 immunohistochemical stain of this same piece of tissue. Underneath this bubble here, we have our control. This is a melanocytic nevus, and we can see in this positive control, indeed, the stain was working because the melanocytes are stained dark brown. So if we go up and take a look at the biopsy specimen, the tissue in question, I'm going to rotate the slide a little bit. And what we want to focus on is the bottom piece of tissue. Again, remember, this was a biopsy of matrical epithelium. And you can see there's a marked increase in the number of melanocytes present within the matrical epithelium. All of these brown staining cells are melanocytes. And you can see we've almost got consumption of the matrical epithelium. There, in areas, are really more melanocytes than there are matrical keratinocytes. And this confluence and Targetoid scatter is diagnostic of melanoma in situ involving the nail unit. One could also use a SOX10 stain, which is a nuclear melanocytic stain, sometimes a little bit cleaner than the MART1 stain, which is a cytoplasmic stain. So first case, slides 1 and 2 represented melanoma in situ involving the nail unit. Very nice example. I'm sure many of you don't see many nail biopsies, so just really nicely taken. The problem with these biopsies, of course, is that they're difficult, and oftentimes the tissue is fragmented or squeezed, or if the nail plate happens to be removed, a lot of the matrix will adhere to the nail plate. So again, a very, very nice biopsy. Moving on to slide number 3, We're changing directions here. Here we have several fragments of tissue. And in looking at this, this is pretty clear that we're dealing with a neoplastic process. It's somewhat fragmented, but seems to be fairly well circumscribed. And at scan, one can see that we've got kind of a blue tumor or blue ball present here. And the blue staining is generally due to hematoxylin staining the nucleus. So we've got a lot of nuclei here that we'll want to take a look at. Overall, even though this is fragmented, the fact that it's fairly well circumscribed would indicate that it's got more of a benign silhouette. If we move to higher power, we can see that we're dealing with an epithelial rather than a mesenchymal tumor. We've got interconnected cords and strands. We have somewhat of a cribiform pattern here. And these are associated with a very loose, somewhat edematous and vascular stroma, a lot of vessels here. As we move to higher power and begin to look at the cytologic makeup of these epithelial islands, we can see that we've got at least two cell types here. The nuclei comprising most of the cells are round to oval. They're fairly large. These cells have some faint eosinophilic to pale gray cytoplasm, although the cytoplasm is kind of difficult to see. And some of these cells have an evenly dispersed or vesicular chromatin pattern, and other nuclei are a little bit darker staining. But these two dark and light staining cells are about the same size. And then sprinkled throughout the tumor, there are several lymphocytes, and these lymphocytes, of course, have smaller nuclei and little discernible cytoplasm. And then if you looked in areas, you could see hints of duct formation within this tumor. And this constellation of findings, the overall configuration, blue balls in the dermis, two cell types, light and dark staining, and a sprinkling of lymphocytes in concert with ducts in the tumor and an edematous stroma are diagnostic of spiradenoma. And of course, this is one of the glandular neoplasm that shows differentiation towards the secretory component of the sweat gland. So very nice example here of a spiradenoma. Same two cell types really can be seen in cylindromas as well, a close cousin of spiradenomas that also show differentiation towards the secretory gland. They generally lack, however, the lymphocytes sprinkled throughout the tumor. And of course, the tumor islands are surrounded by a hyaline sheath, but otherwise the composition of the two tumors is similar. And it's not unusual at all to see tumors that show features of both types of neoplasms in a given biopsy. Moving on to slide number 4. Slide number 4 was a large punch biopsy. And I think this actually was 2 punch biopsies from one lesion, each one bisected. And we can see that we've got an infiltrate filling the dermis and extending into the subcutaneous tissue. The infiltrate appears to be compressing the fat rather than growing in between the adipocytes. And I think at scanning magnification, one of the things that you can really begin to appreciate, not only the fact that this lesion is partially sampled, that it extends to the base and edges of the specimen, but one can begin to appreciate abundant hemorrhage within this tumor. And in addition, we can see some brown pigment near the surface. And common sense would tell you, where there's smoke, there's fire. Since we do have all this abundant hemorrhage, there's a high probability that the pigment, this brownish gold pigment that we're seeing up near the surface of the specimen, is likely hemosiderin rather than melanin. But we'll confirm that when we go down to higher power. As we move in, we can see that the epidermis is slightly hyperplastic. We've got this cellular infiltrate throughout the dermis, and we'll need to go down and take a look at this infiltrate. It appears a little less dense out at the periphery. And if we look out at the periphery, we see a couple of useful findings here. We see some evidence of collagen trapping. So we've got these thick collagen bundles, these collagen balls that are being surrounded by cells that have a somewhat spindled shape. The nuclei are either spindled, oval, or fusiform, and they're kind of wrapping around these collagen bundles. In this same area, we can begin to see some lipophages. So we see these large histiocytes containing lipid. Some of them are multinucleated, and some of these are actually ringed siderophages. So we see large multinucleated histiocytes with a ring of nuclei, and they contain not only lipid vacuoles but hemosiderin. And these are particularly common in this particular lesion that we're looking at. Moving towards some more cellular areas, we do see that we've got a lot of pigmented histiocytes here. The pigment present within these histiocytes, as suspected, is hemosiderin. If you notice, it's got kind of that golden brown color. If you had a substage condenser or a fine focus knob, you would see that it's somewhat refractile, but unfortunately we can't use that particular tool when we're looking at scanned images. But one clue to the fact that we're dealing with hemosiderin rather than melanin, not only is the presence of extravasated erythrocytes, but if you look at the size of the particles within the histiocytes, they're markedly variable. So the hemosiderin is, of course, a breakdown product of the RBCs. And you can see that we've got small granules next to very large, chunky granules. Melanin pigment, on the other hand, which, of course, can be found in melanophages or histiocytes containing the particles, the melanin granules tend to be more uniform in size. And, of course, one can always do special stains, an iron stain, such as Prussian blue or pearls for hemosiderin, and a Fontana-Masson stain for melanin pigment. So in any case, getting back to the lesion in question, we've got a lot of hemosiderin-laden histiocytes here. We've also got, in other areas, fascicles, kind of randomly oriented, of histiocytes and fibrocytes with oval and fusiform nuclei. There's a little bit of nuclear pleomorphism, but if you note, we're not seeing any necrosis or an appreciable number of mitotic figures. And this large cellular fibrohistiocytic infiltrate, again, with the collagen trapping and ring siderophages out at the periphery, seems to be compressing the fat. And the constellation of features in these sections is pathognomonic, of course, for a hemosiderotic or aneurysmal type of dermatofibroma, also known as a sclerosing hemangioma variant of a dermatofibroma. This is a type of cellular dermatofibroma. These lesions can get quite large, and if incompletely excised, do have a tendency to persist or recur. So good idea to completely excise these, because they're certainly not going to go away on their own. Classic example, very commonly asked on boards, and usually spoilers that you could expect in a question given the slide would include things like a blue nevus or melanoma or even nodular cap issues. So be familiar with the features of the hemosiderotic variant of a dermatofibroma. Moving on to slide number 5. This was kind of a cool case. We have a bisected punch biopsy specimen here. If we move into higher power, we can see that the epidermis is hyperplastic and gently papillated. The cornified layer is altered somewhat. We've got some compact ortho and probably a little bit of porokeratosis here. Hard to tell at this power. The underlying dermis contains a patchy perivascular infiltrate of lymphocytes. And if we move to higher power, we can confirm these findings: lymphocytes, dilated vessels, papillomatosis, and epidermal hyperplasia. There are discrete columns and mounds of porokeratosis within the stratum corneum and some dyschromicum cells within the underlying epidermis. And one of the things when one sees these columns of bright pink porokeratosis that one might think about would be a verruciform xanthoma, because you'll remember we tend to get these vertical columns of porokeratosis kind of extending down to a V-shaped invagination of the epidermis, and we have that here. But one thing that we don't have here that one typically sees in a verruciform xanthoma is the presence of neutrophils admixed with the porokeratotic cells. And also, if we look in the dermal papillae between these zones, there are really no identifiable foam cells present within the dermal papillae. Looking over at the far edge of this lesion, however, we can see that we've got this vertical column of porokeratosis with underlying dyschromicum cells in the stratum corneum and an absent granular layer. And this is very characteristic and meets all the criteria for cornoid lamella. So we have this hyperplastic epidermis that is papillated with an inflammatory infiltrate and several discrete cornoid lamellae across the biopsy specimen. And this constellation of features is very characteristic of a variant of porokeratosis that tends to produce papules and at times very large plaques in the genitocrural area, especially over the buttocks. And this is Porokeratosis ptychotropica. It differs somewhat from typical variants of porokeratosis, again, in the marked because of the presence of the papillomatosis, the epidermal hyperplasia, and the multiple cornoid lamella. So Porokeratosis ptychotropica be a very difficult condition to treat, and some of the clinical presentations can be quite impressive. Moving on to slide number 6. With slide number 6, we've got a bisected shape biopsy specimen. Now, one of the useful clues to the diagnosis in this case is recognizing that we've got a dome-shaped papule and that the biopsy is from an acral site. Notice that we've got a very, very thick stratum corneum and a marked to virtual absence of hair follicles within the specimen. We do have kind of this fibrovascular core, and of course, in the center of the fibrovascular core here, we've got several well-defined nerve fascicles. And the spindle cells characterizing these nerve fascicles have the attributes that we associated with neural tumors. They're very delicate, kind of spindled and S-shaped or somewhat comma-shaped nuclei that are tapered on both ends. These cells, of course, would be positive with S100 and SOX10, and their presence is defining for this process. And the diagnosis in this case is a rudimentary supernumerary digit. These lesions, of course, tend to occur along the ulnar aspect of the fifth digit. They're not infrequently bilateral. And the key differential here, of course, is an acquired digital fibroma or an acquired digital fibrokeratoma. And if we had this lesion with the same configuration, but wiped out or subtracted out the nerve fascicles, we would have an acquired digital fibroma. And acquired digital fibromas are nothing more than angiofibromas involving an acral surface. So in this particular instance, diagnosis rudimentary supernumerary digit. Moving on to slide number 7. Slide number 7, we have a trisected shade biopsy specimen. And if we zoom in and study this lesion on low power, we can see that the epidermis is hyperplastic, characterized by very uniform epidermal hyperplasia. The surface of the specimen is gently papillated, and there are some alterations in the stratum corneum. We can see a little bit of basket weave hyperkeratosis, but we also see these zones of perikeratotic stratum corneum, kind of mounds of perikeratosis. And so at this power, possible diagnostic considerations, this could be an inflammatory process, perhaps a psoriasiform dermatitis. Alternatively, because it's gently papillated and got kind of a flat bottom, the silhouette resembles somewhat a seborrheic keratosis. We don't see a lot of horn pseudocysts, but of course there are variants of seborrheic keratosis in which one does not see prominent horn pseudocysts. So those, I think, would be reasonable considerations. However, if we move to higher power and begin to study the epidermis a little bit more carefully, we can see that there's clear-cut abnormal maturation here. We've got full-thickness keratinocytic atypia with nuclei that are pleomorphic. I'm going to zoom out a little bit. And hyperchromatic. There is abnormal maturation with even abnormal hyperchromatic perikeratotic cells within the stratum corneum. There's an increased amount of melanin pigment present within the basal layer. And we can see that we've got an increased amount of melanin pigment and even a few dendritic melanocytes within the epidermis. And so what we've got here is an example of pigmented Bowens disease or pigmented squamous cell carcinoma in situ. One could see similar changes in lesions too of Bohinoid papulosis. And if this was one of many or a few papules on the genitalia, one would have to keep Bohinoid papulosis in the differential as well here. But this is one of these lesions that kind of is a fooler because it has a benign silhouette, resembles a psoriasiform dermatitis or even an inflamed pigmented seborrheic keratosis. But it always behooves you to go down and check to make sure that you've got orderly maturation because architecturally, Bowens disease can resemble a benign keratosis. So pigmented Bowens disease in this case. Moving on to slide number 8. Slide number 8 is the first of 2 interface dermatitis that we're going to be looking at. This is a bisected punch biopsy from the trunk or proximal extremity. Get that down. And in this specimen, we can see that we've got a superficial perivascular infiltrate present within the dermis. We've clearly got evidence of some epidermal change here. The epidermis is quite thin with effacement of the reedy ridge pattern. We have a basket weave cornified layer, but as we zoom in, we can see that we've got pronounced vacuolar change along the DEJ, scattered dyskeratotic cells within the basal layer, and within the papillary dermis, we have a patchy band-like infiltrate of lymphocytes and a few scattered melanophages within a papillary dermis that's somewhat thickened by coarse collagen, indicating that this is probably a long-standing process. Again, note all the melanophages here, and I'm going to zoom in again. One of the points we made with the hemosiderotic dermatofibroma is that the pigment present within the histiocytes or siderophages is variable in size and shape. Now look at the melanin granules within this melanophage, and you can see that they're much more uniform in size than the hemosiderin pigment in the siderophages. Also tends to be a little bit darker staining, but sometimes it can be very difficult tinctorially, depending upon the staining quality, to use color to distinguish the two. Better to use size and context clues. Also note here, we don't have any extravasated erythrocytes here. So much more likely to be melanin, and there's an increased melanin in the basilar keratinocytes. So getting back to the case, thinned epidermis, vacuolar change, necrotic keratinocytes along the basal layer, and a patchy band-like infiltrate of lymphocytes and numerous melanophages. And as it turns out, this biopsy specimen is from a Latin American individual with large hyperpigmented patches on the trunk and extremities. And this was a biopsy of Erythema dyschromicum perstans, which is believed by most people to be a variant of lichen planus, also sometimes goes by the name lichen planus pigmentosus, is a much more subtle expression of lichen planus than garden variety lichen planus, lacks the epidermal hyperplasia, hypergranulosis, compact orthokeratosis, and the inflammatory infiltrate is usually much less robust. This is actually a pretty active inflammatory EDP. In late lesions of EDP, sometimes all you'll see is subtle vacuolar change and melanophages within the papillary dermis. So this is a condition where clinical pathologic correlation can be quite helpful. Without benefit of history, here the differential could conceivably include a drug eruption, a patchy lichenoid drug eruption, or even a lichenoid photodermatitis, less likely a lichenoid expression of connective tissue disease. But this biopsy was from a patient with EDP. And these are the types of changes one expects to see in that condition. One might also think briefly about erythema multiforme, because we've got vacuolar change, a basket weave cornified layer, and lymphocytes. However, by the time the inflammatory infiltrate in erythema multiforme is this significant or this robust, one usually sees many more necrotic keratinocytes in the epidermis. You could also think about a fixed drug eruption, but of course in a fixed drug eruption, one would need to see eosinophils within the infiltrate, and they're absent in this particular case. Okay, let's go ahead and move on to slide number 9. This was another example of an interface dermatitis. We have a bisected punch biopsy here. This biopsy specimen was from the trunk, and one can see that we've got a superficial and deep perivascular infiltrate present in these sections as a vague wedge-shaped configuration. If we look at the epidermis, we can see, again, there's obscuration of the dermal epidermal junction by vacuolar change and a patchy lymphocytic infiltrate. In this particular instance, there's also a little bit of spongiosis with exocytosis of lymphocytes into widened intercellular spaces, and there are some mounds of porokeratosis within the stratum corneum. Within the epidermis, there were a few scattered dyskeratotic cells, not present in great number. And if we look at the infiltrate within the dermis, we can see that it's composed entirely of lymphocytes. In some areas, there were a few extravasated erythrocytes, a few of which were carried up into the overlying epidermis. And this constellation of findings is most suggestive of Pityriasis lichenoides. Clinically, this patient had PLC, or Pityriasis lichenoides chronica. I tend to view Pityriasis lichenoides as running along a spectrum. A lot of times we'll refer to the entire spectrum as Mucke-Habermann disease, with Pityriasis lichenoides chronica being on the one end of the spectrum and pleva being on the other end of the spectrum. PLC being characterized by more scaly macules or scaly papules, and pleva being characterized by more crusted and eroded papulonecrotic type lesions. But the histology of the two conditions is actually quite similar. It's a matter of degree. With pleva, you're more likely, the acute form of the condition, to see more spongiosis, ballooning, necrosis, a denser infiltrate, more necrotics along the DEJ, porokeratosis containing neutrophils. With PLC, similar findings, just a little more blunted. The inflammatory infiltrate may be present around the superficial plexus only. One usually can see some porokeratosis, but there aren't as many necrotic keratinocytes along the DEJ, and a lot of times the alterations within the epidermis are more subtle. But this was an example of biopsy from a patient with clinically documented pityriasis lichenoides chronica. Moving on to slide number 10, this was, I thought, a really cool case. This was a fragmented biopsy specimen. And we can see that the stain is quite blues. Can't discern much here. Can't tell much about the architecture of this lesion because the infiltrate appears to extend to the edges and base. If we move into higher power, which we're kind of relegated to do in this case, we can see that the cornified layer is somewhat thickened, and this biopsy was from near an acral surface. This was from the finger. You can see that the epidermis is slightly thinned with the effacement of the reedy ridge pattern. And then filling the dermis in this case, we have fascicles of uniform spindle-shaped cells. You can see that their nuclei are elongated and tapered. The cytoplasmic margins of these cells are somewhat indistinct. They do have somewhat elongated cytoplasmic processes, and they're arranged in fascicles. Some of the fascicles are cut in cross-section. Here you can see the nuclei appear more round. Some are cut longitudinally, and that's where we see the very elongated nuclei and cytoplasmic processes, and some are cut tangentially. And this gives these fascicles kind of a crisscross configuration throughout the dermis. And hopefully you all were able to pick up on the diagnostic feature in this case, and that's these eosinophilic inclusions within the cytoplasm of these spindle-shaped cells, which are actually myofibroblasts. And once you begin to see these eosinophilic inclusions, you'll be able to pick them up all over. They're in almost every single cell. These, of course, are collections of muscle fibers or muscle filaments. These are myofibroblasts, and these inclusion bodies will stain with actin. They'll also stain red with a trichrome stain and purple with a PTAH stain. These cells, as I indicated, are myofibroblasts, and the constellation of findings here is characteristic and pathognomonic of infantile digital fibroma or infantile digital myofibromatosis. Patients may have one or many lesions, and these can actually, if they're present in large enough number, be deforming. But this also goes by the name inclusion body fibromatosis. And if you ever see it on a pick list, what you want to do is go down on high power and look for the inclusions. This is kind of a high power recognition diagnosis, but high yield. So just a beautiful example. We don't see biopsies very often of this condition. Slide number 11. Again, kind of switching gears here. We have a bisected punch biopsy specimen. This was also from the trunk. And as we move to higher power, we begin to see an infiltrate in the dermis. I'm going to use my pencil and then I'll clear it. That is kind of confined to the upper portions of the biopsy specimen. So the action appears to be here with the dermis. The epidermis may be mildly hyperplastic, but you can see we've got these clear spaces present throughout the dermis. And if we move to higher power, we can see that in the central portion of the lesion, we've got a collection of vascular spaces that are quite large or dilated. Many of these are lined by very plump kind of epithelioid or hobnailed endothelial cells, and some of them contain papillary projections that extend into the lumina. If you look around, you can see these papillary projections. There are a few extravasated erythrocytes present within the stroma. So clearly we've got this vascular neoplasm here with these dilated endothelial line spaces, but it's got kind of a biphasic pattern. Centrally, we've got these dilated vessels, but peripheral and beneath that zone, the vessels are somewhat more compressed. They're still lined by somewhat plump endothelial cells. And in these areas where the vessels are compressed, they kind of appear to dissect between collagen bundles. We even have a little bit of a promontory sign here where we've got these vessels surrounding pre-existing vascular spaces. But unlike the neovascular spaces that we see in Kaposi sarcoma, the endothelial cells here are a little more plump. And we don't have plasma cells within the infiltrate. And plasma cells within the infiltrate can be very useful in discriminating between this condition and Kaposi sarcoma. In this particular case, also the HHV8 stain was negative, which would be positive in Kaposi sarcoma. So the diagnosis in this case was a Targetoid hemosiderotic hemangioma, sometimes known as a hobnail hemangioma. Frequently has a characteristic clinical appearance, occurs commonly on the trunk or extremities, is characterized usually by a central dark blue or purple papule surrounded by a zone of pallor and then an ecchymotic ring, which will slowly resolve. These lesions will stain frequently with CD34, but also are strongly positive for D240. So they probably are of lymphatic origin rather than vascular origin. What one looks for is a biphasic vascular tumor with this central area characterized by these dilated vascular channels. So let's look at the bottom piece, which frequently do contain these papillary projections, which protrude into the lumina, these plump endothelial cells, and then at the periphery, more compressed vascular channels, which dissect between collagen bundles. And it's at the periphery one frequently sees extravasated erythrocytes, siderophages, and an infiltrate of lymphocytes. So Targetoid hemosiderotic hemangioma. Sometimes it can be quite difficult to distinguish these from patch stage Kaposi's. And again, HHV8 staining will help you because these are routinely negative for HHV8, and the Kaposi's, of course, will always stain with an HHV8 stain. And we will close out our discussion with slide number 12. It's kind of a cool case to end on. And we have two pieces of tissue here. And if you take a look at these pieces of tissue, this can actually be a clue to the diagnosis because you can see what happened here. We had this shade biopsy, and then undoubtedly the clinician looked down and saw this pigment in the dermis and said, oops, I think I need to get deeper. And so either the 1-2 shave or a shave and a punch can be a clue to this particular diagnosis. So what do we have going on here? First, let's look at the bottom piece of tissue because this was the initial shave. And you can see that we've got a dome-shaped papule here. And we've got a few nests of melanocytes along the DEJ. And these melanocytes are normal in appearance. They have round oval nuclei and a moderate amount of cytoplasm. And then we have nest cords and strands of otherwise banal appearing or banal appearing melanocytes present within the underlying dermis. There is evidence of maturation with depth in these sections and no mitotic failures. In the central portion of the specimen, you can see that the dermis is a little more sclerotic, and we've got the presence of separately heavily pigmented melanophages. And then if we look at our top piece of tissue, again, we have the more banal appearing melanocytes out at the periphery. And centrally, we've got embedded within a sclerotic stroma, a second distinct morphologic population of melanocytes. Some of these are dendritic, others have spindled or fusiform shaped nuclei. They're arranged in short intersecting fascicles, and in between the dendritic and spindled melanocytes, we have very heavily pigmented melanophages, all set in a sclerotic stroma. So basically, we have here a combined melanocytic nevus, one that has features of both a common or banal nevus and a blue nevus. And this is amongst the most common type of combined melanocytic nevus. By definition, a combined melanocytic nevus has one or it has at least two, sometimes more, distinct clonal populations of melanocytes that have a different morphology. Sometimes this is referred to as a true blue nevus because it's a true nevus or a banal nevus and a blue nevus. But it's possible to have all kinds of combinations. We can get a blue nevus with a spitz nevus. We can get balloon cell nevi. Those are combined nevi because you usually have a population of banal appearing melanocytes and balloon melanocytes. BAP1 and activated melanocytic tumors are frequently combined nevi, commonly characterized by banal nevus and a population of very epithelioid spits like melanocytes. So anyway, all possible combinations are and in actuality, a deep penetrating nevus is frequently a combined nevus with a combination of banal nevus and what looks oftentimes like a cellular blue nevus. So anyway, this is a combined melanocytic nevus. So that's all I have for you. And if you have any questions, again, please feel free to reach out. You can email me at tdavis@sagesdx.com or education@sagesdx.com. Thank you very much. We're always looking for suggestions. So if you have any topics that you would like to have covered, please feel free to shoot me an email. Thanks so much for your attention. Have a good evening.